So thank you, Megan, and KT Canada and the Sport Evidence Alliance for the opportunity to be here today to present. So I will be talking about a project I'm working on, which is engaging patient and public partners in really the design and conduct of the scoping review, which is mapping the science and practice of James Litt Alliance priority setting partnership. Megan, could you just confirm, is the slide progressing?
Yeah, looks good.
Okay, perfect. So before I begin, I'd like to acknowledge that the University of Manitoba, which is where I'm based, is located on the original lands of the Anishinaabe, the Cree, the Oji-Cree, the Dakota, and the Dene peoples, and on the homeland of the Métis Nation. I also acknowledge that Manitoba includes lands that are original homes of the Inuit. I respect the treaties that were made on these territories. I acknowledge the harms and mistakes of the past and present, and I dedicate myself to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. So a quick agenda for today's talk. I've got a lot to cover, so I'm going to try and get through it as quickly as I can. Firstly, a brief introduction into who I am. Then I'll define what patient and public engagement in health research priority setting is. Talk about some of the reasons why we should engage patients and the public in health research priority setting. I will introduce and provide an overview of the James Litt Alliance process. And then finally, introduce my plan for engaging patient and public partners in the design and conduct of my scoping review. So I've outlined 3 learning objectives for this talk. The first is that the audience will have better understanding of what the James Litt Alliance process is, also what the scoping review method is for knowledge synthesis, and finally, my plan to engage patient and public partners in the design and conduct of this work. So firstly, who am I? So I'm a postdoctoral researcher at the George and Sadie Center for Healthcare Innovation, as Megan mentioned. So CHI is a partnership between CIHR, the University of Manitoba, Shared Health, and the Manitoba government, which aims to be a catalyst for healthcare providers, healthcare decision makers, and health researchers in Manitoba to generate and facilitate the use of knowledge to improve the health of Manitobans. So CHI is currently entering into its second phase of funding as home of the Manitoba Strategy for Patient-Oriented Research, so 4 support unit. And there are 7 platforms at CHI. In addition, each platform is supported by a team of experts in patient engagement and patient-oriented research, and I am based in the Knowledge Translation platform. So again, as Megan in my introduction, she mentioned that my interest really lies in advancing knowledge translation for the prevention and management of falls and fall-related injuries in older adults. So my PhD research was focused on improving the use of hip protectors as one strategy to prevent hip fractures from falls in older adults living in long-term care, through both deeper understanding of the barriers and enablers to the use of hip protectors, but as well as the clinical effectiveness. My interest in fall prevention really stems from my personal experiences witnessing my grandfather falling and ultimately fracturing his hip at the age of 84 due to a fall. And unfortunately, my grandfather never fully recovered from his hip fracture and passed away shortly after, and this has really motivated and inspired me in my research. Okay, so that's me on the left. So I completed my PhD in the Department of Kinesiology at Simon Fraser University in 2017. And prior to that, my undergraduate training was also in kinesiology. So I mention this really for 2 reasons. Firstly is I acknowledge I do not have a deep understanding of the lived and clinical experience of falls in older people. And this has really motivated me to engage people with these experiences in the research that I undertake. And secondly, that my my background is primarily in kinesiology, which is quite different from the background that is might be necessary to undertake this work. And so it's been a lot of work for me to try and develop a new understanding of what is patient engagement in health research. And I think a lot of people may be kind of taking this risk and expanding their expertise as well. So what is patient and public engagement in health research priority setting? So it has been defined as the meaningful and active collaboration of patients and the public in really three main components. That's topic solicitation, prioritization, and framing of the research questions. And it really seeks to answer what are the questions that are valued most by patients and the public as they become experts in their healthcare experiences. And when I talk about patients, I refer to really SCORE's definition of a patient, which is any individual with a personal experience of a health issue, which includes their informal caregivers, such as family and friends. And when I talk about the public, I also refer to SCORE's definition, where the public refers to people who bring the collective voice of specific affected communities. So why should we engage patients and the public in this specific phase of the research project when we're determining the research questions to ask in the research process? In scanning the literature, I've really uncovered three main philosophies underpinning or supporting engaging patients and the public in health research priority setting. And the first of this is about democratizing research. So as their tax dollars support publicly funded researchers, it has been argued that people who are affected by research have a democratic right to have a say in what and how research is undertaken. And this philosophy also has roots in the disability movement that coined the phrase, nothing about us without us. According to Guston, democratizing research means that in addition to being rigorous, science must be popular, relevant, and participatory. The second main reason to engage patients and the public in health research priority settings that I've come across is really about increasing the impact of research. So this includes increasing the relevance and accountability of research, but also decreasing research waste. So most notably, in a study published in, I think it was 2009, Ian Chalmers and colleagues estimated that 85% of health research is wasted. Although they identified several potential causes of this research waste, shown here in this diagram, one significant cause was related to the questions that were being addressed in research not being relevant to clinicians and patients. And this included low priority questions being addressed, important outcomes not being assessed, as well as clinicians and patients not being involved in setting research agendas. Furthermore, there is evidence that the priorities of the research community don't always match those of patient communities. In 2000, Talon, Jard, and Ziab assessed whether there was a mismatch between available research evidence and the research preferences of patients related to the treatment of knee osteoarthritis. They did this by conducting a literature search of the evidence base and found that it was dominated primarily by studies of pharmaceutical and surgical interventions. They also conducted focus groups with consumers, which revealed that patients actually wanted more research on education and self-help. And finally, in a survey of patients, they identified that just over a third of survey respondents ranked knee replacement as the highest priority, but a significant proportion also chose education and advice as their first choice. And this is just one example of several which highlights that there is often this mismatch between what patients want and need from research and what research is available. I also came across this quote from Trudy Flynn, who is an advocate and research ambassador from the CIHR Institute of Musculoskeletal Health and Arthritis. reflecting upon her role in a fibromyalgia James-Lynn Alliance priority setting partnership. And she wrote, on reflection, I was surprised by how far apart patients and clinicians were in setting priorities for fibromyalgia research. She went on to say that this indicated to her that there are gaps between what clinicians think and what patients actually need and want. And the final fundamental principle for engaging patients and the public in health research priority setting is about changing the culture of healthcare. This has been phrased as a matter of health equity and social justice, which argues that certain voices, including those of researchers who often inhabit spacious social locations of privilege, should not be privileged over others, and doing so risks excluding the involvement of individuals who often carry the greatest burden of illness, as well as replicating, reproducing, and reconstituting existing inequities. And according to SPORE, this is about building a sustainable, accessible, and equitable healthcare system and bringing about positive changes in the health of people. So what strategies have been used to engage patients and the public in priority settings? So in determining those questions to ask in research. In 2018, researchers from the Alberta SPORE Support Unit undertook a systematic rapid review of the literature to identify what strategies have been used to engage patients and the public in priority settings. They distinguished between two tiers of engagement, which were deliberate and consultative. In the deliberate tier, patient and public partners had greater involvement in decision-making, while in the consultative tier, they acted more as consultants and or implementation specialists. The authors included 70 studies which engaged patients and the public in health research priority settings from a variety of countries, including the US, the UK, Canada, Scandinavian countries, and Australia and New Zealand. Strategies to engage patients and the public included the James-Lynn Alliance Priority Setting Partnership, dialogue methods, global evidence mapping, focus groups and workshops, as well as key environment interviews and surveys. But of the deliberate strategies, the JLA process was the most commonly used, and this is what really motivated me to undertake this current work. So what is the James-Lynn Alliance Priority Setting Partnership? The James-Lynn Alliance is a participatory approach to engage patients, caregivers, and clinicians in what they call priority setting partnerships. So the James-Lynn Alliance itself is a nonprofit initiative that was established in 2004. The National Institute for Health Research funds the infrastructure of the JLA, which is based within a small team at the Wessex Institute of the University of Southampton in the UK. It aims to bring patients, caregivers, and clinicians together in what they call priority setting partnerships to identify and prioritize evidence uncertainties, which are unanswered questions that they agree are most important. And the primary outcome of a James-Lynn Alliance priority setting partnership is to generate a top 10 list of research priorities. According to the James-Lynn Alliance, there are 7 main steps in conducting a James-Lynn Alliance priority setting partnership. So the first of these steps includes creating a steering committee. The role of the steering committee is to define the scope of the priority setting partnership, to develop a plan of action or a protocol, and to identify and manage partners. And according to the James-Lynn Alliance, the steering group should be composed of equal representation of patients, carers, and clinicians. The second step involves gathering data on uncertainty. So these are potential questions that could be asked by research. And this is typically done by asking patients, carers, and clinicians to respond to a survey, asking what questions they have for research, as well as by searching existing literature and clinical practice guidelines to identify evidence gaps. Although uncertainties are typically gathered through a questionnaire, The Jameson Alliance Guidebook states that party sitting partnerships should use a method that is suited to their membership, resources, and infrastructure, and that they should consider how to reach relevant but seldom heard groups. The next step involves summarizing the responses gathered. So this includes removing out-of-scope submissions, categorizing responses or submissions to create summary questions, and then finalizing this long list of summary questions. The fourth step, which may be one of the most intensive, involves evidence checking. So here the long list of summary questions is checked against existing research evidence to ensure that it is an actual uncertainty and hasn't already been addressed by research. So a search needs to be undertaken for relevant and reliable systematic reviews and guidelines that might address this uncertainty, and any questions that have already been answered by research are removed. The next step involves an interim priority setting. So in this step, that long list of summary questions that have been verified as an evidence uncertainty are reduced to a shorter list that will be discussed at the final priority setting workshop. And although an online survey is often used in this stage, steering groups are encouraged to use alternate methods if a survey is not suitable for their particular patient and carer group. So the next step is the workshop. So here's where the identification of the top 10 priorities for research happens, and this often occurs during face-to-face meetings, group discussions, and plenary sessions. So the JLA supports the use of an adapted nominal group technique and recommends that a minimum of 12 people and a maximum of 30 people attend. And then the final step is to disseminate top 10 research priorities to both health researchers and health research funders. So quickly, how is the JLA process being used for health research priority setting? So according to the Jameson Alliance website, there's more than 90 Jameson Alliance priority setting partnerships that have been completed or are currently underway, including several in Canada, which are listed here. And these have really been addressing a variety of topics from a variety of, in a variety of settings and a variety of populations. Very recently, so just this past year, Nygaard and colleagues published a scoping review summarizing how the Jameson Alliance process has been used in health research amongst adult populations. So they identified studies that were published between 2010 to 2018, and of the 37 included, most were from the UK, but a good proportion were from Canada, with a few from India and Spain. So some key findings from this scoping review were that about half of the studies did not include informal caregivers in their steering group, that evidence uncertainties were initially collected, typically using questionnaires, but 2 studies did offer face-to-face methods, that 17 of the studies did not describe how they summarized the responses gathered into a list of summary or indicative questions. The authors of the scoping review did not attempt to summarize any evidence related to how evidence uncertainties were verified. That 14 studies used an online questionnaire during the interim priority setting stage. The authors of the scoping review also concluded that 9 of 37 studies did not include informal caregivers in the final workshop, and they didn't attempt to synthesize the state of the evidence on how PSPs were disseminated to research funders and health researchers. However, although the scoping review provides important new information on how the JLA process has been used, it was limited in that it did not engage patients and the public in the design or conduct of the review. It didn't conduct an exhaustive Gray literature search, which may explain the discrepancy between the number of PSPs listed on the Jameson Alliance website and the number included in their review. And finally, it didn't synthesize any evidence on the science of the Jeyaraman Alliance process. To address these limitations, I will engage patients and the public in the design and conduct of a scoping review with the purpose of describing how the Jeyaraman Alliance process has been used and then synthesizing the evidence that exists on the site. So very quickly, what is a scoping review and why did I choose this method? A scoping review is a method of knowledge synthesis that follows a systematic approach for determining the scope or coverage of a given topic. And while systematic reviews are useful for answering clearly defined questions, scoping reviews are more useful for answering broader questions, which was more consistent with the aims and objectives of this study. Scoping reviews can be conducted for a variety of purposes, including as a precursor to systematic review, to identify the types of available evidence in a given field, to identify and analyze knowledge gaps, to clarify key concepts, and to identify key characteristics or factors related to a concept. So two frameworks have informed my process for undertaking a scoping review. The first is the methodological framework that was first proposed by Arsky and O'Malley, and which was later refined by Levac and others, which outlines 5 essential steps and 1 optional step in conducting a scoping review. The second framework that has informed my process is the PRISMA extension for scoping reviews, which identifies 20 essential reporting items and 2 optional items to include when completing a scoping review. So lastly, my strategy for engaging patient and public partners in the design and conduct of this work. So specifically, I plan to engage members of CHI's Patient and Public Engagement Collaborative Partnership. So the collaborative partnership is comprised of 13 members representing diverse perspectives in Manitoba, including feminist, youth, immigrant, newcomer, refugee, Indigenous, mental health, and disability. And the collaborative partnership works closely with CHI and health researchers in Manitoba to co-create and advise on authentic engagement strategies for involving patients in the public and health research, not only as research participants, but as active partners. So this was touched upon in the last session, but I will use a trauma-informed intersectional approach to engage patients and the public as partners. And this approach is really rooted in principles of health equity and social justice, intersectionality, trauma, and reflexivity. The specific level of engagement will vary at each stage of the scoping review, but is not expected to exceed that of collaboration. As defined by the IAP2, the goal of collaboration is to partner with the public in each aspect of the decision, including the development of alternatives and the identification of the preferred solution. So in the first stage of the scoping review, which is identifying the research question, I held a pre-meeting with patient partners, two patient partners from the collaborative partnership, where we discussed what would be the best approach for them to engage in this process. So we agreed upon hosting first an online workshop to describe the process of the Jeyaraman Alliance as well as the scoping review method. And secondly, an online consensus meeting to brainstorm potential research questions. So very quickly, the purpose of the workshop is to improve the patient and public partners' understanding of both of these processes. So we've outlined a 90-minute workshop. 2 weeks prior to the workshop, we plan to distribute materials to patient partners for review. Presentations will be given by facilitators, followed by the use of active learning strategies, such as participant-led discussions and breakout sessions. We will audio record and professionally transcribe these sessions, and we will evaluate at the end. The objective of the consensus meeting is to identify and prioritize questions and topics that should be addressed in the scoping review. So again, this is going to be a 90-minute online session. We will use the nominal group technique, which includes 5 main steps. And again, will be audio recorded and professionally transcribed, and at the end, we will evaluate this process. We will continue to look for opportunities for continued engagement, including at the stage of developing the protocol, study selection procedures, charting the data, data analysis, and dissemination stages. And progress update, currently we have formed a diverse team with representation from health research funders in Manitoba, Jameson Alliance advisors, clinician scientists, as well as patient and public partners. We've developed a protocol for the engagement in the first stage of the research process, which we have submitted an ethics application for, and we plan to host the workshop and consensus meeting in September. So with that, I'd like to acknowledge my supervisors and collaborators on this project, funding from the Sport Evidence Alliance, as well as CHI's Preparing for Research by engaging patient and public partners at Prep Award. And finally, lastly, I'd like to acknowledge the amazing team that makes up the KT platform at CHI, as well as the patient and public engagement. So thank you.
Thank you so much, Alex. So we're just past the time here, but if anyone has a quick question that they would like to ask, please feel free to send it via the chat box. And thank you so much, everyone, for attending. I apologize, we had a couple technical issues today. WebEx was not completely cooperating, but two really great presentations nonetheless. I will be following up to send the links for the evaluation, so we would really appreciate your feedback on the presentations. We always like to use it to inform and improve future sessions. For our future sessions on that topic, we're going to be taking a break in August, and we will be back on the second Thursday in September. I believe it's September 10th, so mark your calendars. And you can find information, details about that in our KT Canada newsletter and also on Twitter. So let's see here. I don't see any questions coming in. I'm sure people are running to other meetings, but if you do have questions, please feel free to reach out to Dr. Korall directly, and we will be posting the presentations on our YouTube channel, hopefully within the next week or so. So thank you again, everyone, for attending, and especially thank you to LaShonda and Alex for your excellent presentations today. Thank you so much.